Back in 2002, millions of women literally flushed their hormone prescriptions down the toilet, like overnight.
Yeah, it was an absolute mass panic.
Right. The headlines were just screaming that hormone replacement therapy, HRT, was causing heart attacks and strokes and breast cancer. People were understandably terrified.
Completely. And the medical establishment really fueled that fear based on, well, a massive misinterpretation of a single study.
But then you look at the landscape of modern medicine today, and top cardiologists are prescribing those exact same hormones to actually prevent heart disease. I mean, it gives anyone trying to manage their health a severe case of medical whiplash.
Oh, absolutely. The public narrative swung like a pendulum, right? We went from handing out hormones universally to terrifying an entire generation away from a really effective treatment.
So welcome to this deep dive where our mission is to, just cut straight through all that noise. For you listening, we have a massive stack of sources in front of us today.
A really robust stack, yeah.
We've got the British Menopause Society's latest guidelines, some cutting-edge 2026 cardiological reviews, and the most recent long-term osteoporosis data. And we are going to use all of this to answer one very specific question.
Right, which is what are the actual long-term benefits of HRT when it comes to your bone density and cardiovascular health?
Exactly. Because this isn't just about managing hot flushes or night sweats anymore.
No, not at all. This conversation is vital because we're talking about the underlying fundamental architecture of the human body. The key to understanding HRT today isn't just about what these hormones do, but it's entirely about when and how they are introduced into your system.
Okay, let's unpack this because I want to start with the skeleton. The bone data here is just wild, and I'm trying to visualize how these hormones actually interact with our bones on a cellular level.
Well, think of your skeleton not as a static frame, but as a lifelong, highly active construction site.
Okay, construction site.
Yeah, you have this delicate balance happening 24 hours a day. On one side, you have the builders. These are cells called osteoblasts, and they form new bone.
Got it.
And then on the other side, you have the demolition crew. These are cells called osteoclasts, and they break down old microscopic fractures and clear away damaged bone.
So the builders and the demolition crew are just constantly working together.
Exactly. And in a healthy system, estrogen acts as the site manager. It basically regulates the remodeling process by suppressing excess bone resorption. It keeps the demolition crew from working faster than the builders.
But then menopause hits, and estrogen levels just, drop off a cliff.
Right.
So that site manager abruptly leaves the job, and the demolition crew is suddenly left completely unsupervised.
And they go into absolute overdrive. If you look at the recent guidelines put together by Dr. Louise Newson, the numbers are actually quite scary.
Yeah, I saw those.
We are talking about women losing up to a fifth of their overall bone density in just the first 10 years after menopause. Half of all women over the age of 50 will experience a fragility fracture in their lifetime.
Wow.
But then, when you reintroduce that site manager through HRT, the data shifts dramatically. We see fracture risks drop by an astonishing 50%.
Wait, really? 50%? Just by putting the site manager back on the clock?
It is profound. I mean, we have large-scale meta-analyses showing HRT can increase overall bone mineral density by an average of 7% over a 2-year period.
That's huge.
It is. And here's a crucial detail for anyone worried about taking massive doses of hormones. It doesn't take much. Clinical trials demonstrate that even ultra-low transdermal doses, I'm talking something as tiny as 81014 milligrams a day, show highly measurable improvements in bone density compared to a placebo.
Okay, that actually brings up a study in our sources that fascinated me, the one from Imperial College.
Oh, yes.
Because they weren't even looking at menopausal women. They were looking at women with functional hypothalamic amenorrhea, or FHA.
Right. FHA is a really fascinating condition to study because it mimics the hormonal drop of menopause, but in much younger women.
Because their periods completely stop, right?
Exactly. Often due to severe anorexia or incredibly intense physical training, the natural hormone production just shuts down, which puts them at immediate risk for severe, rapid bone loss.
And what the Imperial College team found was that when they gave these women transdermal HRT-like hormone patches or gels, absorbed directly through the skin, their bone density increased by anywhere from 2 to 13%.
Which is fantastic.
But here's the part I really didn't get. When they gave a separate group of these women the standard oral contraceptive pill, it did virtually nothing for their bone density. Like,
Yeah.
why would the birth control pill do nothing? Aren't they both just estrogen?
Well, they're not speaking the same language. The synthetic hormones used in a standard birth control pill do not send the same biological signals to those bone builders as transdermal body-identical estrogen
Oh,
does.
interesting.
Yeah, the birth control pill is often prescribed almost as a reflex by doctors trying to address bone loss in these young women, but it's like sending in a site manager who speaks a totally different dialect.
So the demolition crew just ignores the signal.
Precisely. They ignore it, and the bone just continues to thin out.
Wow. And, reading through Dr. Newson's research, we really can't ignore another hormone here that usually gets totally left out of the women's health conversation. Testosterone.
Yes, testosterone is constantly mislabeled as strictly a male hormone, but it plays a statistically vital role in maintaining bone mineral density for women.
Why is a male hormone needed for a woman's skeleton, though? Like, what is it actually doing?
It's all about how it interacts with the builders. We established that estrogen acts as the manager, holding back the demolition crew, right?
Right.
Well, testosterone binds directly to androgen receptors on the osteoblasts, the builders, and actively stimulates them to lay down more structural framework.
Oh, so they work in tandem.
Exactly. For menopausal women, combining testosterone with estradiol is actually more effective at increasing bone mineral density than using estradiol alone.
Okay, so we have this masterful dual hormone management system laying down all this great new architecture. But I have to ask, so what does this all mean for the long haul? Like if a listener takes HRT for 5 years, lets those builders do their magnificent work, and then decides to stop taking the hormones, are her bones just permanently armored?
What's fascinating here is that this limitation is completely glossed over in the broader conversation about HRT.
Really?
Yeah. The bone benefits of HRT are largely time-limited to active use. It's an ongoing management strategy, not a permanent standalone cure.
Wait, so what happens?
According to the Celeria Bioresearch and the latest NICE guidelines from the UK, when a patient stops HRT, there is a heavily documented rebound effect.
Wait, hold on. So all that bone density you painstakingly built up over 5 years of taking HRT, it just vanishes. You're essentially back to square one.
The demolition crew comes back with a vengeance.
Oh, wow.
Yeah, when that systemic estrogen is discontinued, bone turnover spikes rapidly. The trajectory of bone loss accelerates right back toward an untreated state.
That's terrifying.
It is. The data shows us that in the 1 to 10 years immediately after stopping HRT, a woman's fracture risk rebounds drastically. During that specific window, her risk can become similar to, or even slightly exceed, the risk of someone who never used HRT at all.
That is a staggering detail. So
Yeah.
if you are using HRT specifically to protect your bones, you really can't just set it and forget it.
You must have a transition plan. Now, zooming out past that 10-year post-discontinuation window, the risk curves do eventually cross again.
Okay, so it does stabilize eventually.
Yes, past users over the very long term stabilize and once again show a lower fracture risk than never users. But that initial 1 to 10-year rebound window is a highly vulnerable period.
So what do you do during that decade?
A patient might need to bridge that gap with other targeted bone therapies like bisphosphonates or intensive lifestyle and resistance training interventions.
Okay, so we have this ticking clock with bone health, this dangerous rebound effect when you finally stop taking the hormones. But it turns out there's an even more terrifying ticking clock with HRT, and it has to do with when you start.
Yes.
Here's where it gets really interesting. Because if you get the timing wrong here, we aren't just talking about a broken wrist. We are talking about your heart.
Right, and this brings us all the way back to the panic of 2002 and the Women's Health Initiative study, the WHI.
Right, the one that caused all the whiplash.
Exactly. The entire medical consensus flipped because researchers initially treated all the women in that massive study as a single, uniform group. They just looked at the overall data and saw an increase in cardiovascular events.
But our 2026 sources are telling a completely different story, like
Yeah.
the exact opposite.
Because years later, researchers went back and stratified that 2002 data by age group.
Oh.
Yeah, the fatal flaw was that the average age of a participant in that original trial was 63. Many of these women were starting hormones a decade or more after their menopause had begun.
Which means their bodies had been without estrogen for a long time.
Right. Their vascular systems have been operating without estrogen for years.
And this leads directly into what modern cardiology calls the timing hypothesis. I saw this heavily featured in the 2026 Frontiers Narrative Review, the Alloy Cardiology data, and the British Menopause Society guidelines.
It's the cornerstone of modern HRT prescribing. We finally have modern long-term cardiology trials, like the DTOPS and ELITE studies, which specifically tracked women's arterial health over many years.
And what did they find?
They definitively proved that if HRT is started early, meaning under the age of 60, or within 10 years of the onset of menopause, it actually reduces the risk of coronary heart disease and all-cause mortality by 30 to 50%.
A 30 to 50% reduction in heart disease? That is massive.
It's life-changing.
But what is the actual mechanism making the timing so crucial? I mean, why does a 63-year-old get a heart attack, but a 53-year-old gets a shield?
Well, think of an aging blood vessel like a rusted pipe. Estrogen is incredibly cardioprotective. It keeps the inner lining of your blood vessels flexible, healthy, and free of inflammation. It acts almost like a high-pressure restorative solvent.
So if you start early.
If you start estrogen while those pipes are still relatively clean and healthy, it preserves them beautifully.
But if you wait 15 years...
If a woman waits until she is over 60 or more than 10 years post-menopause to start HRT for the very first time, she has likely already spent a decade building up soft, unstable arterial plaque inside those vessels.
So the pipes are already rusted.
Exactly, the pipes are rusted. At that stage, suddenly introducing a surge of estrogen pumping, that high-pressure solvent, through a compromised pipe can actually dislodge a piece of that soft plaque.
Oh, no.
Yeah, and that loose piece becomes a clot, which leads directly to a cardiovascular event.
So giving estrogen to a recently menopausal woman keeps the pipes flexible. But giving it for the first time to someone who has already built up soft plaque is literally knocking the rust loose.
You've hit the nail on the head.
That completely reframes the entire fear around HRT. It literally dictates whether the treatment helps or harms the heart.
It is a highly sensitive intervention. If you are within that golden 10-year window, it is one of the best things you can do for your cardiovascular health. If you are outside of it, the risk calculation changes entirely.
Okay, so timing dictates if we get heart protection or heart attack.
Yeah.
But does how you take the hormones matter just as much?
Absolutely.
Because I like to think of it like choosing a travel route. You can take the highway straight into your bloodstream, which would be putting on a transdermal patch or rubbing on a gel.
Right.
Or you can take the scenic route, winding through city traffic and going through customs, which is taking an oral pill that has to be heavily processed by your liver. Does the route you choose change these bone and heart benefits?
If we connect this to the bigger picture, the delivery method is just as critical as the timing. The route changes the entire risk profile. Let's look at the highway first.
The transdermal route.
Yeah. Transdermal estrogen, the patches, gels, and sprays, is generally the preferred first-line treatment today because bypassing the liver means transdermal estrogen does not carry the increased risk of venous thromboembolism.
Meaning blood clots.
Right. Oral estrogen can trigger coagulation factors as it gets metabolized in the liver, which slightly increases the risk of deep vein thrombosis or stroke.
Oh, I see.
But transdermal estrogen, going straight through the skin, does not trigger those clotting factors.
Wait, I'm confused then. If taking a pill through the liver actively increases your clotting factors and stroke risk, why on earth would going through the liver suddenly be better for anyone? It seems like an open and shut case patch always beats pill.
It usually is, but the 2026 Alloy cardiology data introduces a highly specific, fascinating caveat.
Okay, I'm listening.
There's one scenario where the oral pill, the customs route through the liver, is actually superior for the heart. It involves patients who have high levels of lipoprotein, a or LPA.
What exactly is LPA?
It is a very stubborn, genetically determined cholesterol particle. Think of it like a sticky, dense bowling ball of cholesterol that is heavily linked to causing heart attacks and strokes.
And I'm guessing you can't just diet it away.
Exactly. The most frustrating part is that it doesn't really respond to traditional lifestyle changes like diet or exercise, but the research shows that oral estrogen is remarkably effective at reducing LPA precisely because of its first pass effect through the liver.
Oh. Because the liver is where the body tries to process and clear that cholesterol.
Exactly. By forcing the estrogen to process through the liver, it drives down those dangerous LPA levels far more effectively than a transdermal patch ever could.
Wow. So for a woman who has that specific genetic cholesterol risk, taking the pill might actually protect her heart better than the patch, despite the general rule about clotting.
Yes.
That is the ultimate example of personalized medicine. We really can't just apply blanket rules.
No, we can't. And the customization doesn't stop with just the estrogen delivery method either. We have to talk about the progesterone variable.
Right. Because if a woman still has her uterus, She must take a progestogen alongside her estrogen to protect the uterine lining from thickening, right?
Exactly. Unopposed estrogen can lead to endometrial cancer.
But doesn't the type of progestogen matter just as much for the breast and the heart?
Immensely. In that infamous 2002 WHI study that caused all the panic, the researchers used an older synthetic progestin called MPA.
And how did that go?
MPA was a disaster for the vascular system. It was linked to increased blood pressure. It tended to actively counteract the positive vascular benefits of the estrogen, and it was the primary driver of the slight increased risk of breast cancer observed in that trial.
It was basically fighting the estrogen the entire time.
Pretty much. Modern guidelines, like those from the British Menopause Society, heavily favor something completely different. Body identical, micronized progesterone.
Meaning it chemically matches the exact molecular structure of what our ovaries used to naturally make.
Yes. The clinical data shows that micronized progesterone has a completely neutral effect on blood pressure.
So no fighting the estrogen.
Exactly. It does not negate the vascular benefits of the estrogen. And large observational trials suggest it carries a much lower risk of breast cancer compared to those older synthetic progestins.
That is such a crucial distinction.
The precision here is everything. The outcomes, whether we are talking about rebuilding bone architecture or protecting the heart's blood vessels, are entirely dependent on respecting those variables.
We have covered a tremendous amount of ground here today. Let's pull this all together. For you listening, the shortcut to being well-informed on this topic is understanding that HRT is not a blunt instrument.
Definitely not.
It's not a magic wand, and it's certainly not the poison pill the headlines claimed in 2002. It is a highly sensitive, precisely timed intervention.
It is a tool, and like any powerful tool, its safety and efficacy depend entirely on how, when, and in what form it is used.
We've learned that it is brilliant for maintaining your bone architecture,
Yep.
putting the site manager back in charge to reduce fracture risk by 50%. But you absolutely have to be prepared for that vulnerable rebound effect if you ever decide to stop.
Crucial point, yes.
And for the heart, it offers profound 30 to 50% cardiovascular protection. But only if you initiate it within that golden 10-year window post-menopause, before the pipes get rusty. So what does this all mean? It means true healthcare is a personalized roadmap, not a blanket prescription.
It really is. And, as we look to the future of longevity, this raises a deeply important question. We know HRT beautifully manages the hormonal axis of bone loss and vascular health.
Right.
But there is a subtle detail in the Celeria bioresearch that I think is crucial to ponder. HRT does not address chronic low-grade inflammation, nor does it address gut microbiome signaling.
Wait, the bacteria in our gut are communicating with our skeleton.
Yes, they are. The gut microbiome regulates nutrient absorption, immune pathways, and systemic inflammation, all of which independently control bone remodeling and the health of our blood vessels.
Oh, wow.
Estrogen is amazing, but it cannot fix a damaged gut barrier. So, the provocative thought here is this. Could the future of menopause treatment lie not just in perfectly timed, body-identical hormones, but in combining HRT with targeted gut microbiome therapies?
That's a huge idea.
Could that be the key to permanently locking in the heart and bone health we've been discussing, bypassing the limitations and rebound effects of hormone therapy alone?
That is a fascinating frontier. And it really brings us full circle. Because 20 years ago, the medical community told us HRT was a simple miracle. Then they panicked and told us it was a universal danger.
Yeah, quite the ride.
Now, looking at the data today, we know it is a brilliant precision tool. And 20 years from now, the headlines might be telling us that the real secret to maintaining our skeleton and our heart was actually hiding in our gut the whole time.
It wouldn't surprise me at all.
It just goes to show the deeper you dive, the more you realize that the architecture of the human body is beautifully, endlessly complex.